Good morning, everyone. It's Donna Gairns from Lymphoma Australia. I'm the National Nurse Manager, and I'm here today at ASH 2019 in Orlando, Florida. And I'm joined this morning by Dr. John Leonard from New York, and he's going to be having a bit of a chat to me today about some of the abstracts and presentations that he found quite interesting, key information that patients should know about. Good morning, John.
Good morning. It's great to be here. Thanks for having me.
Thank you for joining us. I just thought we'd go through a few of the main sort of subtypes and treatments and insights that you found interesting and key for patients to know about. We'll maybe start with follicular lymphoma, for instance. What's some of the interesting abstracts you may have found through that topic?
So follicular lymphoma, as many in the audience know, is at this point really a chronic disease where people may get treated over many years with different treatments. And I think one of the big areas of focus has been what we would term chemo-free regimens, the idea of getting away from chemotherapy. And there were several abstracts here focused on lenalidomide, also called Revlimid, which is has been studied as part of the initial treatment. And has been used and is approved in some areas in the world in relapsed follicular lymphoma, particularly in combination with rituximab. And so what we saw in a couple of abstracts here at the meeting are looking at that agent in patients with relapsed follicular lymphoma in combination with either rituximab, and we saw some data in older patients suggesting that it can be an effective treatment there, as well as younger patients. We always worry whether or not treatments work or are better tolerated or adequately tolerated in both older and younger patients. There were also some data using it in combination with obinutuzumab, also called Gazyva, a newer antibody, suggesting that it may be helpful as well. So that's something that people should keep an eye on because it's becoming more and more available for patients, particularly with relapsed follicular lymphoma.
Yeah, and it's definitely great to know that there's new treatments coming out there and that we're definitely getting better at treating those too. What's maybe some of the key areas in diffuse large B-cell or large B-cell lymphomas?
So diffuse large B-cell lymphoma, I think many people who have dealt with that disease know the R-CHOP regimen, a combination of rituximab plus chemotherapy, which is very commonly used. I think some of the data that we saw at this meeting relate to a couple of different areas. One is the idea of well, first of all, long-term survivors, so people who have had diffuse large B-cell lymphoma and had treatment, which is a large percentage of people because for many people it's a curative treatment and people are in follow-up. We saw a couple of abstracts looking at bone health and the idea that bone density can go down over time after that treatment, or that patients may be at risk of fractures, bone fractures over time. So again, we're still getting into that area and learning more about it, but it's something that people I think should pay attention to if they've had treatment for R-CHOP for large cell lymphoma, because they may be at risk down the line. And so at least talk to their providers and their physicians about maybe they should have assessment of their bone density and so on, because that can happen in some patients. The other areas really are new drugs for patients with diffuse large B-cell lymphoma. We've had what are called CAR T-cell therapies, which have gotten a lot of attention here. These are treatments where the patient's own T-cells, which are immune cells in the body, come out of the patient, are re-engineered to better fight the tumor cells, and then are infused back into the patient. And that has been a useful treatment for a subset of patients, not all, but a subset of patients with diffuse large B-cell lymphoma where the disease has come back. And there are a number of these in development, a number of these that are approved in different parts of the world. And there's a lot of work on trying to make them work better and trying to make the toxicity profile better as well.
Do you see this as definitely a definite way of moving forward, or with the CAR T? We're about to get that in Australia, so it's a big topic there.
It is very clear that there's a subset of patients who have received CAR T cells where it's been a very dramatic effect, and where the patients, again, a subset of patients had very little in the way of options where this has been an effective therapy. On the other hand, that really accounts for only about a third of patients with recurrent or relapsed large cell lymphoma where this has made an impact so far. So that's obviously important for that third of people, but for the other 2/3, more or less, we still need to make progress. And that's what a lot of the work here was, to try to make that work even better.
Sounds fantastic and very promising for those patients, that patient group. Are there any like interesting first line sort of new medications coming through the pipe works?
Well, I think in first line therapy, in follicular lymphoma, I think we're primarily still focused on chemotherapy based regimens, although there were some data with, again, lenalidomide that I mentioned earlier and obinutuzumab, the idea of kind of a chemo free regimen. Whether or not that's better than chemotherapy, it has pros and cons, but it's certainly something that's of great interest. In large cell lymphoma, it's primarily still the R-CHOP regimen. We've seen a couple of studies, some in mantle cell lymphoma, some in large cell lymphoma, where we're using new drugs in combination. And the idea that some of the new drugs may offer advantages to chemotherapy based treatment. On the other hand, just because something's not chemotherapy doesn't mean it's non toxic. So there are trade offs with all of these things. And obviously, we need to compare them to the standard treatments to see if they're improved.
Definitely, and that's a key topic you just mentioned, is that these new medications don't come without the topics. I know that's a big question patients ask me, should I be doing these other treatments and get away from chemotherapy? And they do have their toxicities. Yeah. Oh, fantastic. Any other presentations you're looking forward to later today?
Well, I think the other area that's quite interesting and getting a lot of attention is something called circulating tumor DNA. This is something that's very much at a research stage, but the idea is that all cells in our body have DNA, tumor cells have DNA, and we can, through very sophisticated tests, and again, this is a research test, not something you could ask your doctor to do tomorrow, but the idea is that with a blood test, you can analyze the DNA from the tumor in the blood. And so while there's a lot of sophisticated science behind this, and it's not a perfect test that's ready for prime time yet, the concept is that can you detect the tumor in the blood so that may be helpful for someone who's perhaps in remission, that if they're likely to relapse, you might start a therapy a little bit earlier or be able to predict who needs more or less therapy. It also might be helpful down the line in characterizing the tumor so that perhaps rather than patients getting biopsies to do all of these tests, which obviously have pros and cons of getting a biopsy and the procedures, et cetera, you could potentially do a blood test and get some information on the tumor in obviously a much easier way than doing a surgery or a needle biopsy. And so this is just at the early stages. There's a lot to be worked out still, but it's very exciting. And obviously we have to prove that it makes a difference for patients and that it's reliable, but there's a lot of interest here. And I think over the next several years, we'll see a lot more research going on in this area.
It's very interesting work, and there's been quite a few presentations I've seen in that sort of area, and especially in areas like CLL, they're already looking at that sort of thing too, so it's fantastic. Do you know anything about the lymphoma vaccines?
So there has been work going on in lymphoma vaccines for many years. The idea that you could take a piece of the tumor or some of the DNA of the tumor in a laboratory, then generate something that you could use to vaccinate the patient to strengthen the immune system to fight the lymphoma off better. I would say that those studies or those trials that were done were not really positive from the standpoint of making a big impact. So on the other hand, we have what we would call, so a vaccine is an active immunotherapy where you're relying on the patient's immune system to make the immune response. I think we've largely focused now and seen more success now with either antibody or immune protein treatments that can activate the immune system or these CAR T cells that can actually rev up the immune system in different ways.
Fantastic. It's a question I've got from a few patients as well. So, look, thank you so much for your time and your insights. And it has been a fantastic meeting. A lot of things have come out of this conference, and I'm hoping this will translate into better patient management. It's fantastic. Great. Thank you so much.
My pleasure. Thank you. And I think it highlights that patients need to really pay attention to groups like yours to get the latest information, because things change so quickly. And so really stay tuned and keep up with the newest information that's coming out.
Thank you so much.